Good morning, good afternoon, and good evening. I welcome you all to the SIOG Webinar, Supporting Global Policy in the Aging. My name is Meena Cherian. I'm the Senior Advisor for Global Action in SIOG here in Geneva. In the next 1 hour, we will discuss the impact of COVID-19 on older people with cancer. The ultimate goal for us is to learn from your experience and to take some key collaborative activities for capacity building to meet community needs. Please post your questions on the webinar theme in the question and answer box, which is being continuously tracked. We know that during COVID, the disruptions to non-urgent essential health services, including cancer, impacted the older people, marginalized population, and diagnosis, treatment, rehabilitation, and palliative care. While we are updated with the ongoing global health research on the impact of COVID, we have data from different age groups, coexisting illnesses, including cancer. Therefore, but there is a paucity of data on inequity on cancer services for older people. Therefore, aligning with SDG 17, partnerships and collaborations, such as WHO, multi-stakeholders for global health research is crucial. Firstly, to drive evidence-based policy decisions, and secondly, capacity building to meet community needs on COVID older people with cancer. Now I invite the SIOG COVID-19 Working Group Co-Chair, Dr. Anna Misline, to talk on advocating policies for promoting equity during COVID affecting older people with cancer.
Many thanks, Meena. It is a great honor to have you all joining us from around the globe for this event. I am Anna Mislang, medical oncologist and the co-chair of the SIOG COVID-19 Working Group. The key guiding principle for the provision of patient-centered care for older people is that data-driven treatments are tailored to the specific clinical needs, preferences, and availability of resources. While it is justified to ensure that the most benefit and least harm is provided for the maximum number of people, we have to guarantee that the vulnerable are not disadvantaged and that the principle of equal respect for all is maintained. During the pandemic, policy interventions aimed to mitigate the effects of COVID-19 may increase risks for psychosocial, financial, and health inequities at the global level, and often we need to make challenging decisions which cannot be avoided. These policies may affect vulnerable people and may not only exacerbate pre-existing inequities, but also generate new ones. Older people with cancer are more vulnerable to these adverse outcomes and are disproportionately at risk. Limited to those who have better chances of survival. Next slide, please. Guidelines and policies to support clinicians in making decisions should ideally be all of this. We must protect the and action plans to make them stable. Foster in workload that make full access to resources. International and local prioritizations need to be adaptive and able to respond to and emerging data. SIOG is committed to improving the care of older adults with cancer, especially during the pandemic. Thank you.
Thank you, Anna. I invite now the SIOG President, Dr. Hans Wilders, to share the recent SIOG guidelines on cancer in older people.
Okay, next slide. Hello. So on behalf of SIOG, I would like to welcome you all to this important meeting. SIOG tries to promote the care for older cancer patients in various ways, and the SIOG guidelines are among the very important achievements. And for those who didn't know yet, the COVID-19 working group just published a paper on how to deal with COVID-19 during the pandemic. So welcome, and I pass the word again to the chair. Thank you.
Thank you, Hans. It is pertinent to start our plenary session by understanding the patient's community perspective from Mr. Gessler, the founder and CEO of Advocates from Germany.
Yeah, thank you so much for introducing me, and also thank you for SIOG to address such an important topic. I'm Jan Geisler. I'm one of the initiators of the work group of European Cancer Patient Advocacy Networks, WeCan, and I'm also here as a member of the ECHO Patient Advisory Committee, the ECHO PAC. And of course, we're strongly concerned about the impact of COVID-19 on cancer patients, and we're also fully aware of the issues that specifically the elderly population has. Just very quickly, because we wanted to actually base our advocacy on evidence, we actually made a survey of the leaders of the 24 cancer patient umbrellas in Europe. And on the next slide, you can actually see the mind map that we actually generated, because we actually, in May, we queried all the leaders about the impact in terms of psychosocial and financial impact on patients due to COVID-19, the patient management challenges, the specific challenges of conducting research and trials, because we're aware that cancer patients need to access trials sometimes or are on trials while the pandemic is happening. And then institutional challenges of the patient advocacy organizations, which hinders them from doing what they should be doing as advocacy organizations, but because they can't meet and travel, there are a lot of issues around that. And of course, we're discussing the transformational changes that may stay beyond the acute crisis, or when pandemia gets less, a lot of people are here to, a lot of things are here to stay. That's what we want to find out. And I can't take you in 2 minutes, take you through the whole result, which you can find on the WeCan website at wecanadvocate.eu/COVID-19. So you can see the whole map and play with it when you go to the website. But just to highlight some key facts on the next slide. I just highlighted a couple. You can actually see these kind of clusters, and you can find them on the website, so I'm not going to do that. You see the 4 clusters on psychosocial and financial impact, on patient management challenges, research challenges, and challenges on patient organizations. Now, I've just highlighted some of them which probably stand out in terms of the elderly population. Because one thing that came up from the patient community is the home care crisis, because people can't travel, because support staff also can't travel. A lot of, especially cancer patients and families where the cancer patient needs local care, they don't have anyone to help them while they're really struggling to make their income. So there's a huge home care crisis at the moment, also taking care of elderly on one hand, or of the cancer patient themselves. Then we talk about the benefits, and there is a true benefit in COVID-19 that we are talking about: teleconsultation, virtual stuff that hasn't been possible before because everybody said we can't do this, and now suddenly we can. But of course, it leaves those behind which are not so familiar with technology and working virtual and so on. So that's an issue where we need to think of how can we make sure that everyone can access these kind of technology and make the, let's say, entry barriers as low as possible. Of course, a delayed access to palliative care is what we see frequently, and also for those that are need to go for follow-ups and for monitoring the disease and so on. Traveling to remote hubs is an issue because in some countries, due to the concentration of resources on COVID-19, the number of, for example, cancer centers was reduced during that time just to focus cancer resources on a specific center, which in turn means some patients need to travel longer distance. And especially the elderly population is often not capable of actually doing that, to travel to a remote clinic or and so on. So there are a couple of other issues, and I don't have time, and I can just advise everyone to look at the patient community perspective, which is more in detail on our website. And with that, I hope I could outline some of the key concerns we have. I hope you're all healthy and safe, and hand back to the chair.
Thank you, Mr. Gessler. I know that time is, we have very limited time, but we are wanting everyone's perspectives to be shared. So next, joining us from the WHO headquarters, Geneva, Switzerland, we have two global public health leads from the two WHO programs most relevant to our theme today. I invite first Dr. Andre Ilbawi from the Cancer Program.
Dear friends, dear colleagues, it's a pleasure to be here. Thank you to the SIOG leadership for the opportunity to speak, and to our dear Dr. Cherian for chairing this session. I'm so pleased to be able to share this platform with many of you esteemed colleagues and friends from around the world, because in reality, this is the front face of the pandemic for us in the cancer community. Thank you also to our WHO colleagues. As you will hear throughout the session today, WHO in all its capacities and across countries and regions stands ready to support the governments and the cancer community in this response. And one last word of appreciation as we get started. Many of you we know are on the front line. It is important that we pause and appreciate you for what you are doing to care for cancer patients and to ensure that the most vulnerable continue to receive the care that they need in spite of the challenges that the pandemic brings. So given that our time is limited, let us just focus on what we know and what we must do. First, what we know. As we have already heard, cancer services are disrupted globally. A recent WHO survey has in fact highlighted that for more than half of the countries around the world, cancer services have been impacted in a meaningful way. For us, we wanted to know more. So we've gathered data through systematic reviews, through country inputs to understand why is that the case, and surely we'll be discussing that throughout the session today. But as we've already heard, what we also want to focus is on the lens of equity and on the most vulnerable. Who are those that are still at home needing stronger home care, as we've just heard? These are dimensions that we want to focus on as we now create the real narrative on what we must do. So that is another part of our current response, which is what are evidence-based mitigation strategies. In that regard, we've also done a systematic review to understand what measurable strategies have been put in the peer-reviewed literature. Unfortunately, we only found nine total. So clearly we know we are responding, but there are deficits in how we measure and how we report it. And if we are going to promote evidence-based strategies, we must publish our evidence, because currently we know that many groups are creating fragmented recommendations based on best practice, but not based on evidence that we can generate today. So let's start that and respond to that challenge now. So what must we do from here? As mentioned, first, measure, report, and share best practices. At WHO, we now have a platform to help countries understand the impact of COVID on cancer services and to plan mitigation strategies. This is a cancer-specific tool for COVID that each country can use to understand how many patients are being impacted negatively from COVID and what can their response be. It looks at delays in diagnosis, interruptions in therapy, treatment abandonment, disruptions in supply chains, and other parameters that can help governments understand what is this evidence-based response that is needed. A communities of practice is also being developed so that we can in fact share what we know and encourage other governments to do the same. And second, we must continue to work together as a community to generate community-led consensus mitigation strategies. We know that the evidence is slowly being generated, so forming our strategies based on data alone remains a challenge. But this is where community input remains so important. To have a truly multi-sectoral dialogue, and I do appreciate us starting with the patient perspective, because at the end of the day, that is what matters most. So when we develop our recommendations for how professional societies, academia, research groups, patient advocacy networks can respond, let us continue to do this together. If we are able to found it on evidence and on consensus, we will surely have a positive impact the world around. Thank you again for the opportunity to speak, and I look forward to a fruitful discussion today as we take on this very important challenge and the COVID pandemic that continues to threaten our communities worldwide. Thank you.
Thank you, Andre, for setting the scene for partnerships, collaborations, and specifically on global health research. You've clearly mentioned what we can do, what we have to do. I now invite my friend, Dr. Sumi, from the Aging and Life Course program.
Thank you, Mina, for the introduction. And I'm honored to be with you together to talk about care for older people in the context of COVID-19. I was taking care of older people as a primary care physician, as well as emergency and critical care physician in Japan for more than 15 years before joining WHO. So I witnessed, what is the concern of older people and how we can tackle these needs, diverse needs. As you know, older people have been especially hard hit. The case fatality rates due to COVID-19 in people over the age of 60 is almost 15%, which is 10 times higher than that of younger people. This case fatality rate increases in those with underlying conditions that affect immune, cardiovascular, and the respiratory systems. It means including the people with cancer. In many countries, more than 40% of COVID-19 related deaths are linked to long-term care facilities. Older people are told, stay at home, and this pandemic has left older people isolated from families and friends and probably community services. It has made daily activities more challenging and sometimes impossible. Older people hesitate to go to the healthcare facilities as they are afraid of transmission of COVID-19, even though it's needed. This novel virus has revealed the vulnerabilities and the inequalities in health and social care systems. Since the beginning of the pandemic, WHO has worked with leading experts and partner organizations around the world to develop the guidance to protect older people, their families, and communities. The topic of guidance includes infection prevention and control, clinical management of COVID-19 patients, specifically for older people, maintaining essential health services for underlying conditions, and the prevention of abuse and violence. Recently, we have published policy brief to prevent and manage COVID-19 in long-term care facilities, from integrating long-term care in the national response to mobilizing adequate funding and to provide support for family and caregivers. What we have learned and learning from COVID-19 pandemic, we should consider this as an opportunity to transform health and social care system to better respond to the need of older people. As you can see in the slide, in this August, the member states of the 73rd World Health Assembly called for 10 years of concerted action to foster healthy aging by endorsing the decade of healthy aging up to 2030. The vision of decade of healthy aging is a world in which all people can live longer and healthier lives. This is an opportunity to bring together governments, civil society, international agencies, professionals, academia, media, and the private sector for collaborative action to improve the lives of older people. There are 4 action areas you can see in the slide. And number 3 is delivering person-centered integrated care and primary health services responsive to older people. Strengthening primary health care to deliver accessible, affordable, equitable, safe care for older people will require sustainable, appropriately trained health workforce with competence in aging, including comprehensive person-centered assessment and the integrated management of chronic health conditions. Building on the profound experience and the network of SIOG, we can work together on capacity building of health and social care workers in primary care. Before closing my remarks, I would like to remind you, tomorrow is the UN International Day of Older Persons. There are some events happening. Please join us. Thank you very much.
Thank you, Yuka, for that perspective from the aging population and specifically addressing for cancer and essential health services, which includes cancer. Next, we have 3 interesting field experiences from the WHO regions on enhancing collaborations for supporting capacity building at country level. I will invite first Dr. Prebo Barango from the Non-Communicable Disease Inter-Country Support Team for East and Southern Africa, the WHO Office for Africas.
Thank you very much, Dr. Mena Sherian. And thank you to the organizers of this webinar for this very important topic on older people and how COVID-19 is impacting on cancer care. Let me start by saying that the COVID-19, pre-COVID-19, there was a lot of gap, especially in the African region, in terms of cancer care for older people. Most cancer patients present late due to systemic and health systems constraints. There is inadequate human workforce. Experts are not in adequate numbers. Oncologists and nurses are not. And where they are, the few numbers are usually concentrated in big city centers. So there is a huge access gap. This is pre-COVID. What COVID has done now is that it has just exacerbated and made this glaring inequality more acute. More acute because, as you have mentioned, we had a survey that showed that cancer care has been severely disrupted by COVID-19. But it does, so building, as part of building back better, it won't, we actually need to start from where we were before COVID-19 and build and strengthen. The focus now on the SDGs and UHC, I think it's an opportunity for us to leverage and harness on the PHC. My colleague that spoke last mentioned about decentralizing training for frontline healthcare workers, because these are more in numbers and in terms of distribution, they are better, closer to the communities where most of the people and older people with cancers live. So it will be useful and a good an approach that WHO Afro we are taking is looking at training and developing capacity of nurses, primary care physicians to be able to take care of, to respond to the needs of cancer patients in particular, in general, but specifically looking at the older population and their needs, which spans from prevention, intervention, which also goes to early diagnosis, up to palliative care. We know that this has been disrupted, but we also know that if we empower these frontline healthcare workers, it's going to ameliorate the current situation where you have a lot of gap in availability of services. So the way to go will be in developing their capacity. One thing to consider also, and what COVID-19, we have learned from COVID-19, the lesson we have learned from COVID-19 is the use of the internet and web-based platforms. I mean, we couldn't, a year ago, we couldn't imagine we could have as many fruitful and productive meetings on without face-to-face contact. So it's also something that we really, moving forward, will be a great approach to improving the human resource gap and deficit that we have in the African region. Thank you very much. I'll stop here.
Thank you, Dr. Barango. It's very nice to hear about the frontline health workforce, and that we can use the currently the internet and all these media, how we can do the training. With that, now I invite my friend, Dr. Wheeler. She's the sub-regional advisor on human resources for health in the WHO Office for the Americas to share her experience.
Good morning, everyone. Good morning, Mina. Lovely to see you. Thank you, SIOG colleagues, for organizing this very important conference. We must not forget at any point in time the vulnerability of older persons with cancer. COVID-19 has brought unprecedented morbidity and mortality to the Americas. And you may be aware that there are over 16 million cases and 552,000 plus deaths in the Americas due to COVID-19. In the Caribbean, where I'm based, we have over 221,000 cases, just over, and 3,792 deaths. And unfortunately, the account for something like 55% of cases here in the region of the Americas, which is very sad indeed. So there has been, as a result of COVID-19, disruptions in services for non-communicable diseases as a whole, and of course, cancer is included there. And the elderly have been particularly hard hit due to the reduced mobility and access to services. And we continue to see a rise in deaths of older persons from the pandemic. But of course, those who have underlying diseases are particularly prone. A PAHO survey of 80% of our member states has shown that access to essential non-communicable disease services, including outpatient services, have been affected, finding that 64% of the services for NCDs are open, but with limited access and or staff or even alternative locations. 36% of these inpatient services were open in the 80% of member states that were surveyed. And the elderly are particularly hard hit, we know, as I mentioned, because of the high numbers in the Caribbean of NCDs, mostly cancer, diabetes, and hypertension. And cancer is the #2 killer in NCDs in the Caribbean. We are in a situation where the elderly fear going to hospitals or clinics for treatment for fear of contracting COVID-19. But the pandemic has shown us that we need to work together much more closely, and it's the only way we will reduce the morbidity from the virus. We have seen from our statistics that there is an expected 67% increase in cancer rates in Latin America and the Caribbean if we go back from 2012 and we project forward to the end of the Sustainable Development Goals in 2030. In fact, from the 1.096 million cases in 2012 and the projected 1.831 million cases in 2030, just over 1 million of these are expected to be in persons over the age of 65 as our population in the Caribbean begins to age. For PAHO member states, we have listened to the voices of our countries, and they have requested support in 4 critical areas. Communication, and this is particularly, again, important for elderly people. How do we reach those people who normally would come into clinics, who would access services on a regular basis, and who are now afraid to access such services? So communications materials in all forms, data and information collection, certainly looking at excess mortality due to COVID-19 in persons with cancer and other NCDs, looking at the reasons for reduction in services, some of which I've just barely touched on, technical guidance and support, and of course, capacity building and the use of telemedicine services, which is becoming more and more critical. As the previous speaker, my colleague from Afro said, who would have imagined that we would be using the internet so much? And this is becoming a very common method of delivering services. Telemedicine and virtual information has become more and more important in offering services to older persons who cannot or will not access services in person. Therefore, the government is critically aware, as with the situation of joining the COVAX facility globally, that the elderly, persons over 65, and those with underlying health conditions, particularly non-communicable diseases, and here, of course, we include cancer, have been prioritized, we know, globally. And the governments of the Caribbean have made a commitment to ensuring that this vulnerable population is served when and if there are vaccines. On a previous occasion, speaking at a SIOG summit, I spoke about the need to collaborate with training of healthcare professionals. This was anticipated to be in person, but now we see the importance of continuing to work with SIOG and other partners in conducting virtual training sessions for healthcare staff, which has now become the new normal in our part of the world, in order to build competency in the area of geriatric oncology. Our virtual campus for public health in Paho is well structured and available to facilitate the hosting of such courses and modules, which would serve the health professionals in the region of the Americas. I take this opportunity to reconfirm our commitment in Paho to supporting the work of SIOG and to supporting the work of addressing the needs of vulnerable populations, such as older persons with cancer in the region of the Americas, and in particular in the Caribbean. Thank you for your time.
Thank you, Erica, for telling us the situation, the challenging situation in the Caribbean and Latin Americas, and specifically talking about the telemedicine and teaching through the internet and all for all the people, reaching out to all the people. We next have a perspective from the WHO Country Office for India, Dr. Atri Ganguly. Dr. Ganguly, you could
Am I
unmute.
audible now?
Yes.
Yes.
We
Okay.
can
At
see
the
you as well.
outset, thank you. At the outset, many thanks to this SIOG for giving WHO India an opportunity to present here. And I would also congratulate, because the timing of this meeting is very pertinent, because all the countries are having issues, and especially in countries like India, where the elderly population is growing at a very fast rate. This is a very good learning experience for all of us. So in terms of what India has been going through and how WHO India had been supporting the country, I would like to keep you informed that the government of India has acknowledged that cancer is one of the underlying factors for COVID-19. Also, elderly population is a very vulnerable group, and there is a need to include it in the package of essential non-COVID services. So right at the beginning, in the very early days, when the government sent out directives to the states. As you know, India is a federal country. We have the central government, and health is a state subject. But the central government has the the rights to share guidance to the state, and state will then can further enact according to their adaptability. So guidance were given to the states to ensure that the services continuation of non-essential essential non-COVID services like NCD medication, cancer, palliative care, elderly care should continue. It empowered the primary healthcare level workers, primarily the frontline workers, to follow up and facilitate appointments as appropriate. Also, in order to avoid the spread of COVID-19, because it is highly contagious, appropriate measures were being taken to adhere to the directives, which include the COVID appropriate behaviors. From government of For the government of India, WHO India had been supporting in maintaining the essential services both for the COVID and non-COVID sectors. uh, WHO is a member of the task force which has been set up by the government of India to take appropriate measures. Our focus had been to empower the communities and individuals to take control of themselves and to adhere to the COVID appropriate behaviors, because it is government alone cannot win the war, and India with its high population and population density, the individuals and communities must take up ownership in order to win the fight against COVID. And this included protecting vulnerable groups, including the older population, and especially because these older population usually come with lot of underlying conditions, and also the essential health workers and frontline workers who were supporting this endeavor were given special emphasis. So, in terms of support and capacity building and hand holding of the government, we were continuously sharing regular WHO updates and global guidelines on different pillars of COVID 19, which also included the availability of essential non COVID services. There were many best practices from other countries, especially the countries who have been doing well on the COVID front. They were shared, and how the essential services were maintained in these countries. Also, the how to engage with the key stakeholders, because India being a large country with a huge population and population density high, with limited resources, we really need to reach out to the other stakeholders, because government alone cannot win this war. So we helped in engaging the government with the other key stakeholders who were very spontaneous, and they all collaborated. So this has been some major contributions. In terms of capacity building, I also echo the sentiments of my previous speakers who said that COVID-19 had brought in an opportunity to explore the IT platforms, and these were very useful because it kept in line the COVID advisories. Telemedicine, teletherapy were being helped. Also, also then risk communication and community engagement, especially in terms of the older people, because older people were perceived as they are more susceptible. So there were many people were feeling that they may be the ones who would spread the infection. So there was a dire need to have risk communication and community engagement to demystify these myths. So from our office, the risk communication section was going ahead, and also there is an initiative by the government which we are supporting, which is saying that to fight COVID, wherein risk communication played a major role. Also stigma discrimination, because as I said that elderlies were considered, they were maybe the potential spreaders, so there was some stigma discrimination issues. Also the health workers who were supporting the cause of the elderly, there were also some stigma discrimination issues. So government also brought about some stringent measures to prevent that. And right, we are yet not at the end of post COVID. In fact, COVID is on, and right now our policy is that since we are opening up, our country is opening up, the lockdown is being revoked, so we have to take care of ourselves, so that we do not spread, especially take care of the older people, because the young population, we go out through work and then we may bring back the infection to the elderly. So these are the few underlying messages which I would like to share. Thank you once again for giving me an opportunity to bring the perspective from India. Thank you.
Thank you, Atri, for that perspective from India. Specifically, we really wanted to hear what the situation was. And moving quickly now to public health leaders in the governments and ministries of health have a prominent role in moving policies. So therefore, I invite Dr. Cairo, Deputy of Health, National Integrated Cancer Control, including palliative and hospice care, and thyroid disorders from the Philippines.
Good day, everyone. First off, I'd like to thank SIOG for inviting me to be a part of this activity. So we have around 109 million Filipino people. 8.2 million are older people, or senior citizens as we call them. And about 60% of them have non-communicable diseases, including cancer. And we know for a fact that there's a deadly interplay between COVID-19 and non-communicable diseases. So if older people are prone or vulnerable to COVID-19, more so the older people with non-communicable diseases. So at the outset of this COVID-19 pandemic, the government, under the leadership of our president, created the Interagency Task Force. It's a whole of society, whole of government group, which will lead in the COVID-19 response. And last July, we came out with the policies and guidelines, namely the interim guidelines on the continuous provision of services for cancer diagnosis, treatment, surveillance, and palliation amid COVID-19 pandemic. And the second one, interim guidelines on the continuous provision of health services for senior citizens. They are the one aged 60 and above amid COVID-19 pandemic. So at this time, we are thankful that the mortality have drastically improved. The age bracket mostly affected is age 20 to 40. So that means the response, the measures of the government, let's say implementing the quarantine, as we call it, it's a mild term for lockdown, because we see to it that the senior citizens or the older people will not be going to the mall. Okay, so we limited their movement. They are advised to stay at home. Okay, and older people with cancers are, of course, being prioritized to go to the hospitals. They will be scheduled, and telemedicine is being used. Actually, digital health is now a necessity amid this pandemic. And that will be one of the priorities of the government, maybe in the near future. So I think that's all for our country, the Philippines. Thanks very much, and be safe, everyone.
Thank you, Dr. Cairo, for giving us a perspective from the guidelines from the government. We move now to Dr. Reza, Dr. Reza Ashadi, School of Medicine, Mashhad, University of Medical Science from Iran. If we are not connected, I think he's running late. We can have him after this. So is there?
Hello.
Yes.
Hi, everybody. I thank you for the time for me for this meeting. I was wondering if I could have a good presentation here because of the very difficult situation that this year we have in my country due to not the difficulty of economic and political issues, but also the presence of COVID-19 pandemic, that in this case our country has faced one of the most challenging health problems because our hospitals was formerly full of patients and customers, that now when they are facing the new cases of COVID-19, that there is no cure exactly for it, and also there is no appropriate therapeutic protocol. The reports that we have in the country is that there is a very, very dramatic drop of presence of the chronic diseases in the hospitals, to be afraid of the COVID-19 infections. And this is also happening for the cancer patients because they are seems to be vulnerable and not safe against COVID-19 infections. And so the reports that is about 16% decrease in the follow-up, in presence, and in continuum of the treatment protocols. And it seems that by this drop of presence and the visits of these patients in the hospitals and the private clinics, we might have a rise in mortality and morbidity rates of these patients because the people are avoiding to be presenting themselves to the doctors, to be presenting themselves to the hospitals. And this is beside of the lack of hospital beds for these patients due to being followed by COVID patients. And so these two events put together by, I think that in the end of this year or the next year, we will have a rapid rise of morbidity and mortality of cancer patients. And so I think before it is too late, it should be a consensus and a global movement, because I think this situation will be the same in many other countries. We should have some sort of commitment and a consensus, global commitment to find solutions and make telemedicine methods, or I don't know, home care services, or technology-based solutions that find the cancer patients, follow up them, and push them to continue the treatments and send the treatment to their homes. I don't know what is happening in other countries, but in my country, the situation is not very good because most of the budget, most of the efforts are on COVID infections, and so the cancer patients are not finding the good situations. I think the possibility of the technology that is now helping many countries in case of education, in case of communication, should come more active and more effective, and using it for health services. I think health services are not providing in this situation good for the patients. And I think that some research activities also should be done. This is examples that if you know about Global Circ group, in Global Circ group, they have opened a chapter for COVID-19, and they are moving the conditions and the objectives of the group to focusing on the combination of on their main objectives and COVID-19. And I think some of the studies like them should be done by the society that are active in treatment of cancer patients, especially in old patients, that they are not also vulnerable to malignant diseases, and the mortality are high with these diseases. They are also vulnerable to the COVID-19 problem. And finally, I think some sort of a network of people who can help should take part in the regional and the global level to make the connection between the experiences that we are obtaining in place to place, to share it. I think that in the case of sharing of experiences is not happening very effectively, that it is also can be a solution for many of the problems that many of us are facing in our own regions. Thank you. Excuse me for not to be very ready for this presentation, and I am with you. Thank you.
Thank you, Dr. Sadi. And from the perspective, and we move now to, and I invite Dr. Hussain Khalid, Professor Emeritus of Medical Oncology, National Cancer Institute, Cairo University from Egypt.
Thank you, SIOG, for inviting me to attend this important webinar. And also I thank the chairman. In Egypt, where the normal population is around 100 million, and according to the official numbers of the World Meter published about Egypt, so far we have around more than 100,000 COVID-19 cases, with about 6,000 deaths. At the same time, and we had the peak of cases was in May, June, and July, and then now we have a lower number of cases, but we expect to have a second wave. And I personally think that we need to live with COVID for a long period to come. So we have to be ready for this situation. At the same time, and according to the National Registry, we have around 128 new cancer cases per 100,000 normal population per year. And we see now many cases of the geriatric age. So what I really want to the SWOG to take lead is in first thing is to make proper and strong teleconsultation among different areas and different agents, as there are fragmented guidelines for diagnosis and treatment of these cases. And the second point, I want also, if it is possible, to try to have guidelines for dealing with cancer cases having COVID-19, not to low-income countries and high-income countries and so on, but to low income scenarios in the same country or other countries, and high income or middle income scenarios and high income scenarios. The third thing, which I think it is also important, is to try to do research, common research between different countries led by the SIOG, especially in geriatric patients having cancer. Remind you also that we have the World Cancer Day by the UICC in 4th of February, and I served as member of the board of the UICC for 2 years, since 2 years. And I think that we have to make benefit of this day in order to also encourage people to face this problem. which we all are dealing with. In Egypt, we tried to make guidelines in May and June for cancer patients, especially for those who are old, and we tried to give more oral therapy, chemotherapy, than being on systemic IV needing hospitalization. We tried also to postpone chronic cases where the surgery can be postponed for 1 or 2 months. For the pediatrics, we also tried to have certain guidelines. It is not the time now to go into details, but I think that we have to have common guidelines for these different scenarios. And again, I thank you very much for letting me to participate in this very, very important event.
Thank you, Dr. Khalid. We'll quickly now move to the experts who have joined us from academic institutions which are responsible for education and research at country level to give their perspective. And I invite Dr. Martin Exterman from the USA.
Good morning. Yes, so from a more ground level point of view about how practically we can address COVID in older and how it affects older cancer patients, I think every institution has had to figure out how to care for these patients with all the restrictions in mobility, but also all the messaging that's going around. And honestly, in the US, there is a lot of mis-messaging that as experts we have to handle and try to keep evidence-based approach, as our WHO colleagues were saying. We really need, as experts, to stick with the facts, create the evidence, collect the evidence to manage these patients. And initiatives can be sometimes very grassroots. Our fellows at Moffitt did connect with fellows at other cancer centers in the US. And they just created a webinar, a training webinar for fellows and any faculty who wanted to hear about simply COVID and how to handle it and what the institutions were learning managing these patients. And so I think this is also an approach, a very grassroots approach that we could use for how to manage older cancer patients in various local specific settings. From my local experience, I would highlight a few points that I think we need to pay attention to for older cancer patients. Number one, they are very sensitive to the risk of infection if they go outside of their home. And we had to message as a center that we're actually a safe place. And cancer centers are usually well located because we do infection prevention on a chronic basis. And we had to emphasize that message. We had to make it visible to our patients. We screen everybody, we screen our visitors. Another aspect that we need to pay attention is many places have restriction policies on visitors, and inpatients and outpatients cannot have visitors with them in the room. This can be a real problem for older patients if they have hearing problems, if they have mobility problems, if they have cognitive problems. This can impair communication and retention, or simply knowledge problems about cancer that they don't feel equipped and would like to have family come. So we had to be creative, and we devised a system where we had a room downstairs for family members on an iPad to be able to be present in the visit room via an iPad, for example. We can also have exception of one member accompanying the patients if we have cognitive issues. So these are issues that particularly affect older patients. On the other hand, telehealth is an opportunity because people with limited mobility can sometimes be seen by telehealth with a family member present at their place. I will stop here.
Thank you, Martin. I will quickly now move to hear the perspective from the American Society of Clinical Oncology by Dr. Enrique Soto.
Hi, everyone. Thank you for inviting me to speak today. As a member of the board of the American Society of Clinical Oncology, I was invited to give a perspective of what ASCO is doing to tackle the COVID-19 pandemic and to help patients and clinicians during these difficult times. So I think that ASCO, as many other organizations, has a pivotal role to play in this issue. And I think that many of the questions that have been raised during this webinar can be tackled and should be tackled by international organizations. I think that ASCO especially is working hard in creating registries, looking at the real data about the outcomes of patients. I think that many of the things that we talk about now do not have hard data to support them. And many of the things we are doing are kind of adaptations in times of crisis. But we do need this difficult data, and we are working on it. And I think that having this real world experiment will provide a lot of information, and we will actually be able to see what's going on with our patients with cancer. Another thing is creating educational opportunities for providers. I think people need to know how to adapt to these times and how to use scarce resources to provide high quality care. And finally, I think that organizations should push for policy changes. I think that particularly in the area of telehealth, the changes that have been made to telehealth rules during the COVID-19 pandemic should continue to be in place after, and that we have to make it easier for providers to do this without having to use very specialized software. And perhaps one of the ways in which we can connect with patients in an easier way is to ease these restrictions and to allow for the use of other types of softwares like with end-to-end transcriptions with smartphones. So I think we have a lot of opportunities in the future, and that societies play or should play an integral part in the COVID-19 response. Thank you.
Thank you, Enrique. I invite now Dr. Matti Abro to share the perspective from the European Cancer Organization.
Good morning, good afternoon, good evening, everyone. Thank you for having asked the European Cancer Organization to say a word here. Of course, we are extremely concerned by what is going on, what has happened, and especially concerned about what is going to happen. SIOG is a member of the organization, and we hear from the perspective of the older patients, but we hear from the perspective of all patients. And we should also not forget that this crisis affects all citizens and all diseases. And the crisis is not only in oncology and not only in geriatric oncology. We have tried, as we are an umbrella organization, to help our members communicate with each other. We have created a specific area on our website, and we have created a task force that allows all members that have to deal with this issue to communicate with each other. So compliments to SIOG for having had this initiative of putting all of us together at this table, and let us continue to work together. And especially, this was underscored by several, improve our communication, because our communication from all of us, starting unfortunately from our governments, has been extremely faulty. Thank you.
Thank you, Dr. Abro. And we now move to get the perspective from the European Cancer Patient Coalition perspective from Ms. Antonella Cardone.
Hello, everyone, and thanks to SIOG for inviting me to present our perspective, which is the patient's perspective. So I represent ECPC, which is the European Cancer Patient Coalition, and it is the largest cancer patient umbrella organization in Europe. Of course, we tried to address the uncertainty of COVID-19 on cancer patients from the very beginning. And what we have managed to do is a web hub dedicated to COVID-19. And we are providing updated information, and we did that from the very beginning. At the beginning, we tried to calm down the fear that cancer patients had, and specifically elderly people with cancer. Then we have developed guidelines, including, so it was there were guidelines collecting all the available guidelines from scientific societies. So we did that, and also we reinforced specifically on cancer and elderly people an initiative that we have launched in 2020, and that is the cancer-related complications and comorbidities, because COVID-19 has highlighted, has put the eye spot on comorbidities and cancer, and aging is one of these comorbidities with cancer, according to us. And so within this initiative, we are focusing our attention on the importance for elderly people to continue to be screened, collecting data, and so involving more and more elderly people into clinical trials, and also providing the right care for elderly people. So that is, so we're focusing on the geriatric assessment. And of course, cancer patients needed to be more and more supported and informed, so that they can make an informed decision when it comes to the treatment. Thank you.
Thank you, Ms. Cardone. We quickly now go to the exciting part. I'm sure everybody is waiting to hear about the questions that they have proposed. And this will be chaired by Dr. Niccolo Battisti and his team.
Thank you very much, Mina. It's really great to see this collective effort today taking place, and this really, beautifully reflects the global scope of our society. We have 10 national representatives of SIOG on the line today, and I have collected a number of questions that I would like to relay to the panel and our national representatives. There are some common themes that I have identified during your talks. First of all, I think there is the issue of collecting data on the impact of COVID-19 in older people with cancer. Obviously, initially during the webinar, there was a question about what are the metrics that we should really try and capture in large data sets. Are we interested in mortality, survival, or is there anything that we could aim to capture instead in a population of patients which is obviously subject to competing risks? I would like to direct this question to Dr. Ilbawi and Dr. Sumi from the WHO, if possible, please.
I'm not sure my colleague is online, still online. From my perspective, from our perspective in terms of older patients, actually, when we developed the clinical guidance, we realized we have very little known about older patients. And then I searched, I talked to geriatricians. So what do you find? Is it different from the younger COVID patient compared to older patient? And then they described, there are a lot of atypical symptoms. We say that in the beginning, there is a cough, there is a fever, and older people may present in different way. So we realize this is really important area to collect the data and then understand what is the unique symptoms or unique needs of older people. Because we tend to think to put in one box older people as older people or people with cancer, but in reality, it's different. So it's very important to collect have an international national effort to collect the real data from the patient. Thank you.
Thank you very much, Dr. Sumi. That's a very good point, and I guess this is what SIOG has been advocating for 20 years. There is no one size fits all. My other question, and I think this came up quite a lot during the Q&A, is what should be our recommendations from WHO, stakeholders, scientific societies, healthcare systems in low versus high income countries? How can we really tackle the differential impact of this pandemic in older patients in these two different settings? I would like to ask these questions to our WHO region and country representative, Dr. Barango, Dr. Wheeler, and Dr. Ganguly, if possible. I don't know if they are on the line.
Yes, we're on the line, but I don't know which order.
Thank you.
And
you can make a start if you wish.
Okay, so you are asking about recommendations on low versus high income countries.
Correct.
I think we can't forget that we need to continue to support essential health services. And we are in a situation, I mean, in the Caribbean, we have both. We have both high income countries, very high. In fact, Trinidad and Tobago, where I am now, is considered a high income country. But in reality, countries in the Caribbean, when they're called high income countries, it's a bit of a misnomer, because all it takes is a hurricane or two and we descend to being low income countries. So I think the focusing still on essential health services and strengthening health services for NCDs, because in the Caribbean, we have an extraordinarily high rate of NCDs as a whole, right? So what I think we need to be doing is assisting governments and helping them to focus not only on COVID, because we know at the beginning, this has been the issue, that you have limited resources and you're throwing your resources into one particular area. But it is about continuing to help to shore up essential health services and health systems in such a way that when we begin to come out of the pandemic, we are not faced by another kind of problem, which is the fact that our health services have gone backwards so much, which has begun to happen, that we are losing ground in terms of ensuring that primary healthcare services continue to be shored up. You know, in PAHO, we talk about 30-30-30, ensuring that 30% more people have access to primary healthcare services, 30% more of expenditure from the government is being spent on primary healthcare and so on. So I think it is continuing to ensure that government does not put all its eggs in one basket, because at the end of the day, we are all going to be worse off. And we see this trend already, where essential health services are not where they should be, even in immunization. So I think continuing to focus and to support governments in keeping their health system strong is the way to go, because when we do that and we ensure that persons with NCDs, as part of that, that the services, all the services continue, because we still have the staff and we get the funding, say for COVID-19, but we have to make sure when we get funding for COVID-19, we don't spend it all on PPE. Okay, which is a challenge that we're having in our part of the world, that we invest in services for persons with NCDs, and in particular, older, vulnerable people, and we strengthen our telemedicine and other services where people don't have access. So we have to be creative, and we have to continue to ensure that we don't go backwards and put all our eggs in a COVID-19 basket with PPE. Thank you.
Thank you very much, Dr. Wheeler.
Yes, thanks. Taking on from what Dr. Wheeler said, in the African region, it's similar. It's a mixed bag. We have high income countries like South Africa and Nigeria, and we also have low and middle income countries. And we have the smaller land countries, for example, are a case in point, where most of them are either middle or high income. So the focus, like Dr. Wheeler had mentioned, is about ensuring that the essential services are maintained, meaning that we need to ensure that health care workers feel safe to go back to work and provide services, and that the community and the patients have confidence that when they go to the health service facility, that it is safe and they are safe and they are able to get these services. So that will be the priority, and the focus will depend now on country context, because, for example, even in South Africa, it's high income, but you have a lot of social inequalities that is not uniform across the country. So we really need to look at the country context and even have to go region by region to see what the key issues are and be able to address this. So it's not a one-size-fits-all approach. Over.
Thank you, Dr. Barango. I would like to ask a last question. We got quite a lot, and we were actually planning to answer all the rest of the question remotely while offline. But I think it also there was one which is also particularly relevant. With regards to telehealth, how can we really engage with governments and obviously to keep the momentum and make sure that we ensure, for example, in countries like the United States, ongoing insurance coverage and government support across the countries. I would like to direct this question to perhaps Dr. Matti Japro from the European Cancer Organization, because I know that his organization is really doing a lot to feed into the Europe Beating Cancer Plan here in Europe, of course. Thank you.
Well, overall, where do we stand? The Beating Cancer Plan is running on time in spite of the COVID crisis. Of course, it will have to take into account some of the needed changes in approaches because of the COVID crisis. But fundamentally, like in all areas of medicine, we should not forget that with all due respect for the suffering that COVID is imposing on the citizens and on, of course, the patients and those who unfortunately died, we have also many other issues that we have to face, and we should not forget them in spite of this crisis.
Thank you very much, Dr. Japro. If this is okay, Nina, I would like to close the Q&A. I would like to thank everybody for sending the question. We'll try to answer them all remotely after the conclusion of the webinar, because there are so many and so interesting. Thank you very much again.
Thank you, Dr. Battisti. And understanding the perspective of the patient communities, policymakers, academics, and your experiences from the field, I invite first Dr. Brian and then Dr. Kaneswaran to share with us the way forward for SIOG collaborative activities with WHO and multi-stakeholders for capacity building on cancer in older people in countries.
Oh, Yes, thank you. Good afternoon, good evening, good morning to everybody. And I'm very pleased to report shortly on what is doing or what is working on SIOG for this COVID-19 crisis for our older cancer patients, because we've known through the different presentations how they accumulate both excess risk related to cancer and to aging with viral infection. They have a very high risk of inappropriate decisions, so that's a double inequity. Yeah? Inappropriate decisions on cancer treatment, because sometimes there is a shortage of core materials for providing sustained, safe and high quality cancer care. And so what is really key, what is probably the essential in what I understand, is that the discussion with the geriatric team, as much possible, whenever it is the best way to get to appropriately balanced decision. And so in consequence, training young generations, patients also, but societies, the community, how to use that and how to support it is key. And that's where, next slide, we have some examples, because SIOG has developed a set of different webinars, workshops, courses, advanced courses across different area of the world. And it has set also collaborations with organizations, bigger than SIOG by itself, like ESMO, like the Elderly ESMO SIOG Working Group, working on preceptorships, fellowships, webinars, shared sessions in our respective meetings. And that's very important to improve the quality of practice amongst the new communities that we will take over from the older ones that we represent sometimes, in order to improve globally this management of older patients. So training, education is key. And the last example I would set is next slide, is what we've developed with the SIOG Advanced course, which has been set or started almost 6 years ago with 6 editions. The 7th was missed in 2020, but the 7th will take place next June, hopefully, depending on the crisis. But all that is to stress that it's only through this way. Of course, there are some differences across countries, but in terms of we have constantly some common issues for the older population. They are poorly treated with poorly evidence-based data. They require more adjustment, de-escalation, and patient-centered priorities are first, are really priorities. So all that should be expanded beyond the borders. And that's what we're trying to do in terms of education through these different actions. So that's all what I wanted to add to this beautiful webinar that we had so far today. Just to mention that we were able to train or to create some good network through more than 100 young physicians representing more than 20 countries. So that's something that we need to work on, and we need to continue. Thank you very much.
Dr. Kaneswaran.
Hi, Meena. Thank you so much. Hi, I'm Ravi Kaneswaran, President-elect of SIOG, and it gives me great pleasure here to welcome all of you to this and for all your contributions. So in closing, I would like to highlight one of the key reasons why this is happening as well, which is alignment of SIOG with WHO recommendations on cancer in older adults. Earlier, Dr. Meena Cherian had very aptly mentioned SDG 17, which is about partnership and goals, sustainable development goals that UN had come about, had created in 2015. So here I'm going to go through other areas in which SIOG and WHO can work hand in hand, and how a lot of our goals are actually aligned very, very closely. Next slide, please. So here, as I mentioned, just dovetailing on what I said, you can clearly see there are common goals between what WHO has for cancer care and also what SIOG has achieved in its 20-year history. So in many areas, in the past 20 years, SIOG has been able to increase overall scientific evidence in geriatric oncology. We have formed numerous task forces to come up with guidelines to assist this group of patients who for longest time have been, in a sense, neglected because of lack of knowledge and information on how best to treat them. We have tried our best to improve the quality of life of these patients and offer possibilities for professional development and growth with some of the activities that SIOG conducts. And I think Etienne had very nicely mentioned some of the training and advanced courses that we conduct. Prior to this was always held in Treviso, and for the first time next year, it will be in another continent in Australia and Canberra. And we hope to also increase global collaborations and partnerships. And that's what this whole conversation this evening by Singapore time, but this day is about. And all this is with one goal in focus, which is to hope that every oncologist will realize that they are a geriatric oncologist. It's part and parcel of who they should be, and it's part and parcel of the care or the skills that they should have in delivering the best care possible for older adults with cancer who come to see them. Next slide, please. So first, I'll start with the WHO report that came out this year on cancer. This was sometime in February, around the World Cancer Day period. And just to highlight, apart from cancer being a big issue, and many of you are familiar with the disease burden that cancer is and how it's growing rapidly, also how investment can actually save lives. And what their data has shown is that clearly with some good investment, you can actually save a significant number of patients who are unfortunately down with this disease. Next slide, please. SIOG, on the other hand, after about a decade, which was about 9 years ago, had come up with its list of priorities as well. Dr. Exterman, who's on this call, led that initiative, and this was called the 10 priorities at that point in time. And after 9 years, for this year, we actually have an update. Next slide, please. And in that update, clearly SIOG outlines 4 major areas, which is education, clinical practice, research, and last but not least, collaboration and partnerships. And that's what we're looking forward to with this collaboration with WHO. And one of those things that we highlighted in that manuscript was also, the next slide, please, how SDG 3, which is about health and well-being, is another area where we have a common goal. And this is obviously, pretty clear because one of our aims is to assist older patients with cancer to ensure they have a good quality of life, they get proper coverage. We look at preventive issues as well, and strengthening capacity and trying to get as many oncologists, or not just oncologists, any specialists who deals with cancer patients, researchers, allied health, to understand the key principles of geriatric oncology and use them to help this vulnerable group of patients. Last slide, please. So with this, I would like to firstly mention that tomorrow is UN International Day of Older Persons, as mentioned earlier, and as part of the Decade of Healthy Aging, there are a number of events that WHO has organized. We ourselves are going to have our 20th anniversary annual meeting tomorrow. So it's time to celebrate 2 decades of SIOG legacy and hopefully many, many more decades to come. And before I end, I would like to thank many people here, but basically to summarize, Dr. Battisti, Dr. Cherian, Nadia, and the organizing committee for this event, the pre-SIOG meeting event, WHO and SIOG leadership, and also all of those who have taken time off to attend this event, including SIOG members, supporters, and those who may not have joined SIOG yet. Please do consider first step to it, maybe just attending our meeting tomorrow. So hope to see all of you there soon. Thank you very much.
Thank you, Etienne, and thank you, Ravi, for concluding. And now before we close, I want to share some exciting news. On October 3rd, the landmark of Geneva, the Jet d'Eau, that's a water fountain, will be lit up in the color of SIOG to mark the 20th anniversary of SIOG for healthy aging and improved quality of life and older cancer patients. I would like to thank the panelists and each one of you for joining us and sharing ideas for future SIOG webinar topics. Wish you all well and keep safe wherever you are. Good day, good evening, or good afternoon. Thank you.
Thank you very much. Very glad to attend at this meeting. Bye.
Thank you very much.